And I assume everybody can see the screen.
Yes, we can.
I'll go ahead and proceed. Good afternoon, and thank you, Michael, for the introduction and allowing me to present the Rural Veterans Healthcare Atlas FY 2014. My name is Justin Ahern, and I'm a geographer, and I work for the Office of Rural Health in the VHA. And my other wonderful team members listed above were also instrumental in the development of this atlas that we produced as a team effort. There was some delay in the release of the atlas, but now that we've hopefully mastered the approval process, subsequent editions of the atlas will be released that much faster. So today I'm going to give you first background on how the atlas came into being, and then an overview of the first 8 chapters. So let's take a look. The idea for the atlas came out of a previous work that was done in support of the Office of Research and Development. The FY 2000 Healthcare Atlas was published in FY 2003. It was well received, and it was hosted on the HSR&D website for several years as a resource for researchers in the VA. We then proposed to the Office of Rural Health that a rural healthcare atlas was needed, and then we were funded to do the work in FY 15. So we used the latest full fiscal year of data from 14 and focused primarily on the rural veterans. Importantly, FY 14 represents the latest year of legacy definitions. In FY 15 and forward, numerous changes have taken place, including the definition of rural changing from census-based to RUCA, the classification of VA facilities changing, the number of visits changing from 21 to 18, as well as some other important policy initiatives, including the Veterans Choice Program. We're going to be incorporating these changes into subsequent releases of this atlas. We're going to do it annually. The FY 15 is currently in production and should be out by the end of the year, and then the FY 16 we'll start working on that in January. So let's get started on the content of the atlas. So Chapter 1 provides some information on rural veterans, enrollees, and patients. Throughout the atlas, each chapter has an overview that describes where we got the data, the methods we used, and the maps and tables. And then we also included some summary highlights at the legacy VISN state and county level. The maps shown here on this slide depict the rural veteran population estimates based on the VetPop 2014 model and the American Community Survey. Tables with total number of veterans broken down by rural and urban are shown in the chapter as well. And the maps here show both a volume and % of rural veterans by state. The data were classified into 4 groups, or 4 classes, quartiles, with the lower 25% in the lightest color and the highest 25% in the darkest color. We also looked at information on veterans who enrolled in the VHA, and these maps presented on the slide show the number and percentage of rural and highly rural enrollees at the VISN state and county levels. We compiled this data from the VSSC, the current enrollment cube, using end of FY 14 data. Again, the data are mapped by quartile. So we also dug a little further in and looked at, we mapped out subgroups of enrollees, such as gender, age, enrollment priority groups, such as service-connected veterans. And the chapter also, in addition to enrollees, also looks at patients who are seen in the VA during FY 14 with maps, tables, and information describing them too. Chapter 2. So now we start to look at the physical locations and ruralities of the VHA medical facilities. We used the VAST, the VA Site Tracking Database, in the VSSC, and at the time we compiled this data, there were 150 VA medical centers, with 21 of them located in rural areas. Facilities of all types were mapped out on a national level, a national scale, and then we provided maps zoomed in at each individual VISN level with facilities and the layer of rurality, which was based on the U.S. Census legacy definition. The maps and the VISN scale maps also contain a small table that have a count of rural facilities by type for a little more information. The next slide is going to talk about Chapter 3, which takes a different turn, and we wanted to look at where rural veterans went to seek care. So while it's not, it's not very surprising that the largest percentage of rural veterans visited VHA facilities in rural areas, sometimes that wasn't the case. There were in cases where rural veterans needed more specialized care than what was available in their community, so often they would have to travel long distances to services in urban areas. So the chapter here features tabular and spatial data with VHA facilities, and then what percentage of those patients who go to those facilities reside in rural areas in FY14. Chapter 4, this chapter looks at non-VA facilities, which could be both a place of supplemental care and locations of possible partnerships for care. We have tables with counts and percentages, and we looked at the top 5 non-VA facility types. And we chose to look at FQHCs, rural health clinics, Indian health services facilities, military treatment facilities, and critical access hospitals. We also mapped out non-VA facilities and their location in relationship to our VA medical centers and CBOCs, with examples shown here for VISN 2 and the old VISN 18. And then the next chapter, we get a share at the VA health services that are used by rural and highly rural patients. And we focused on outpatient encounters and then broke those encounters down by rurality. So kind of similar to what we did with enrollees and patients in Chapter 1, we also looked at subgroups, gender, age, priority group, low income, and then we mapped out those data by VISN state and county with numbers and percentages. And these 3 maps are examples of those, numbers of highly rural and highly rural encounters. Chapter 6, we start looking at, we compared the general population and the VHA enrollee population using the county health ranking measures. And we looked at 4 healthcare-related access measures and overlaid those results with our VHA enrollee population dot density data to kind of show the distribution and clustering of the enrollees and to get a sense of the gaps in care. So the left map shows the percent population under 65 who are uninsured, and the right map shows the rate of primary health care providers per 100,000. So you can kind of visualize the counties where there's a very dense number of VHA enrollees, but they have a low number of providers, for example. The rate of dentists and the rate of mental health providers per 100,000 were also displayed as chloropleth maps with the VHA enrollee file overlaid in dot density format. And again, all these data were categorized into 4 classes, quartiles. Chapter 7, we look at the health technology access in areas. So this data was provided by broadbandmap.gov, and there's a link in the presentation. And broadband was defined as a download speed of at least 4 megabits per second at the time of FY14. There were some nuances with how they grouped and broke out their data speeds. So our group opted to use the speed of 6 to 10 megabits to do the analysis. And we used typical download speeds as a reliable measure in that data, and we also looked at only wired internet because telehealth units mostly are hardwired. And then we look at we took our VHA enrollee data, broke it down by rurality, and examined how many enrollees were inside and outside of the broadband coverage areas. So on these maps, broadband speeds were simplified into 2 categories. So we have 6 megabits per second or over download speed in purple, and the under 6 megabits per second download speed in pink. VISN 2 and VISN 5, shown here on the slide, are examples of lower download speeds and higher download speeds, respectively. Areas that were not purple nor pink either do not offer wired internet or they have no data available. And in FY15, the definition of broadband is actually changing to from 4 megabits to 25 megabits per second download speed. So we're going to update that in the next edition of this atlas, and we're going to also look into wireless coverage. And so in addition to the last 7 core chapters I just went over, we also have 10 standalone medical disease chapters. This chapter, diabetes, is a prevalent disease in rural and highly rural areas. So after we extracted the data and analyzed it, we got it from the VSSC as well, the diagnosis cube. We confirmed the proper ICD-9 codes and then began producing tables and maps, including the maps you see on this slide, which show the volume of VHA patients with diabetes. And we have that mapped by Vision, state, and county. So after we looked at the overall diabetes, we then focused in on those diabetic patients living in rural and highly rural areas, and we mapped those patients out by legacy, Vision, state, and county as well. We also looked at subgroups again. We looked at male and female, 65 and older, low income, service connected. And so this map here is an example looking at number of VHA rural and highly rural female patients with diabetes by state in FY14. And we have tabular data and narrative information also highlighted in the chapter. So in addition to diabetes, we have 9 other medical disease standalone chapters which have useful content organized in the same fashion as the diabetes chapter. And the diseases we were chosen here because the data we used to compile this atlas suggested that rural areas in the United States had sizable cohorts, and that healthcare access and delivery to these particular types of cohorts should be examined and addressed. So that about wraps up the overview. As I mentioned earlier, we're currently working on the FY15 edition. That's our 2nd edition of this Rural Healthcare Atlas, and we're starting to explore ways to make the atlas more interactive through a portal or web applications, and make it more dynamic. So we'd very much appreciate any comments that you have, and we would be happy to answer any questions. Our contact information is here. And also be sure to check out our atlas. It's now available on the web. And I appreciate everybody's time. Thank you so much.
Justin, thank you very much. Very informative.
You're welcome.